everybody. Welcome to our, what are we now? November, I think, Q&A session on treatment-induced menopause. My name's Rachel Udamapu, and really pleased to see you online this afternoon. We've got a huge number of people joining, which is really exciting. Now, for some of you women with more nuanced questions, you can also phone the Breast Cancer Foundation Nurse Advice Line, and there's a number here, 0800 226 8773, and that will give you one-on-one support, and we can pop that in the chat box for you. Absolutely excited to bring you this session on treatment-induced menopause. Now, our wonderful guest speakers are going to give you some really clear information and practical strategies and direct access to specialists to help you manage the sudden and physical emotional changes that can come with treatment-induced menopause or natural menopause that's been made more complex after a cancer diagnosis. So it's my absolute pleasure to introduce Dr. Megan Ogilvie and Dr. Anna Twigg, who are going to help us demystify the menopause transition, explaining why these changes happen, the symptoms you may experience, and the options available to sort you through this time. So, ladies, I'd like to hand it over to you.
Thank you, Rachel. My name's Megan. I am an endocrinologist, a reproductive endocrinologist, and I work at ERH Associates, and I'm going to let Anna introduce herself.
I'm Anna Twigg. I'm a GP who's worked in general practice for about 30 years before coming here, and I started off doing deliveries and looking after women, and I've now gone back to that in a full circle to join Megan and her team.
So we've been really excited to get Anna on board with us. We've both really worked in the area of menopause and women's health for probably about 25 years now, and just to set the scene a little bit, it has been a fascinating time to work in this area. I remember being a junior doctor in the 1990s, starting women in the coronary care units on hormone therapy because we thought that it was going to prevent their second heart attack. Do you remember that time?
I do.
And then in 2002...
The criteria for going on hormone replacement was being 40.
Yeah, it's about right. And then the Women's Health Initiative trial came along in 2002, and prescribing of hormone therapy stopped overnight. It wasn't just about prescribing hormone therapy, though, because menopause treatment and management really mirrored this, and we lost a lot of education in general practice, and a lot of funded, very reasonable options that Pharmac had for us were just taken off the schedule. So it was a real step back in menopause care. And since that time, we've both watched the pendulum swing wildly between these two extremes, and are hoping at some point it might settle somewhere more sensibly.
And I think because of this, in my last practice, I was the only one who knew about menopause hormone therapy. So lots of the young doctors are a bit nervous about it. And when you come along with nuanced information, particularly about your care, it's actually really helpful for them.
And I think you guys, just by definition, generally make them a little bit anxious, having had a cancer diagnosis, and there is certainly more to think about. And I'm very aware out there today that we've got different women with different cancers at different stages in all of this. So we're going to try and set the scene a little bit, and then talk more about what menopause is and what options are available.
And just before you start, Megan, on that same note with the GPs, they're very much focused on your cancer and treating that because they're a bit nervous. And so I think it's really important for you all to say that your quality of life issues, and put them in the forefront, because I think that they are likely to just put that to the side and not think that it's a priority for you.
So let's just have a look at a bit of the messaging that has happened over the last few years, and why women may be feeling a bit confused about this. I think you would have had to have been hiding under a rock for a long time now to have missed the moment that menopause is having right now, and it certainly feels like everybody's talking about it. Back in 2002, these were the kind of headlines that were published, which were pretty frightening around hormone therapy use, and this is when prescribing stopped. this void of good medical therapy was filled by people like Suzanne Summers and backed by Oprah Winfrey prescribing bioidentical hormones, and that became an industry that made the bioidentical hormone industry billions of dollars. Then we've had a lot of commercialization of menopause, with somebody always trying to sell you something that is supposed to help with really not much evidence backing any of it. In addition to this, there's been quite a lot of different messaging for women over the last few years, from the point of view of menopause as a natural transition and we shouldn't be medicalizing menopause. And if we just stop talking about it, it would all go away and be better. To actually, everybody should be using hormone therapy. Hormone therapy will do these amazing things and is the elixir of youth. And then there are a tsunami of memes, jokes, stand-up comedy acts that might, on some level, make us all smile, but ultimately really is about minimizing women and putting them up on a shelf and hoping they age and go away. And none of us really want to do that. So I would like you to contrast that with this. And the Maori word for this transition is ruahine or ruahine tanga. And ruahine means wise woman. And the Maori cultural lens on this transition is that women move through it to become the kuia of the tribe or the wise woman of the tribe, with a lot to give their local community and their whānau. Actually, it's not just the Maori culture that see this. Many Indigenous cultures have this belief of the transition. And it's fascinating to see that this is aligning with what is happening in science. There's a lot of information recently about cognitive change and neurological remodeling over this time, and the growth of the scientific term crystallized intelligence is seen here. So that's our kind of higher level thinking, our ability to analyze information, our wisdom, our life experience. All of those things continue to grow over this transition, despite some verbal memory issues, which we're going to talk about. And I think it's fascinating now to see that this is aligning with what probably Indigenous cultures have known all along. So Anna and I see in our clinics all the time women who come in and they say to us, my oncologist has done a great job, my surgeon has done a great job, I've had this really great team around me, but now I am left to pick up my life and I am struggling to do that. And what are our options and what can we do? And so we're going to talk a little bit about what has happened, perhaps for you, and why this has happened, what the perimenopause is, what the symptoms are, hormone therapy for those for whom it's relevant, options around non-hormone options. And then I just wanted to finish by talking a little bit about libido and testosterone, because I think that's an area we get lots of questions in.
I know, and also too, as we were discussing before, a lot of people think of menopause as libido.
Yeah.
And we are trying to make the message that it's not just about that.
No, it's a much bigger picture than that. So let's see how we go. So I suspect there is a real mixture out there as to how this has happened for women. So some women will have gone through a more natural menopause, which looks like a last menstrual period somewhere between the ages of 45 and 55. But actually, some people may have had an earlier menopause that may have been induced. So iatrogenic means that doctors have induced it, basically. And it's possible that some women may have had their ovaries removed, so a surgical menopause. It's possible that women have lost ovarian function with either chemotherapy or radiotherapy as part of their treatments. For women who have an estrogen-sensitive cancer, then aromatase inhibitors or tamoxifen can be used, and they can also induce menopause. And some women are on something called a GnRH analog, which is a medication that stops the signaling of the pituitary down to the ovaries, and this can also make women hormone deficient. Just to give you a feel for definitions, that normal range is considered a last menstrual period between 45 and 55. Early is considered between 40 and 45, and premature younger than 40.
No.
No? Okay.
The only thing I was going to say about that is the reason we have those definitions is because it depends on what parts of the body we have to look after, depending on when they stop having their own hormones.
Yeah, I think what we have to consider, and this is always a nuanced discussion with somebody who has had a cancer diagnosis, and I'll go on and talk about that. But people who lose ovarian function early can be more at risk of, we need to think about bone density and heart health and brain health. Whereas if it's that more natural age of 45 to 55, those things are not generally so concerning. I think one of the most important parts of this talk is to understand the impact that the symptoms can have. I think we see this all the time because we're seeing so many women come in and talk about this. But the symptoms can be quite insidious and creep in at a time of life that there is a lot going on, and you've got lots of different things pulling you in different directions. I think that typically doctors see women a little bit late, especially by the time women get to us. Often women have stepped down from jobs or decreased their hours or left relationships, made very, very big changes in their life without really understanding why they're feeling the way they're feeling and understanding that there are things that they can do about it.
And one of my patients actually mentioned how when we go during puberty, and you go from a free little girl to someone who's now having to manage monthly periods and all these symptoms and emotions, and that's just a really big change that we don't really even think about. And lots of girls do it, and then they're trying to cope with boys and adolescence and acne and their secondary school education. And I feel as though menopause is quite a similar thing. And women, because we've always just managed everything, we've managed how we felt after having children or all those sorts of things. We just sort of have been taught to suck it up and move on. And I think that at this particular time, particularly if you're dealing with a cancer diagnosis and your confidence might be a little bit low because you're wondering about what's happening with work for the next few months, etc., it's very easy for us to do the same thing here. And I've had husbands who had no idea that their wives were suffering because they put on such a good act. So I think it is a really good time to talk about it. Think about yourself as a whole woman, and maybe even if you're having therapy help, to actually look at this as one of the things to focus on.
Yeah, I think they're good points. There's also, I mean, there is good data to show that women who've gone through a surgical menopause generally have a tougher time of it with symptoms. And the key to that is what menstrual cycles were like prior to having your ovaries surgically removed. If cycles were regular, then you've got very normal, regular hormones, and basically within 48 hours, you become hormone deficient. And so you do that to sort of perimenopausal stage, which most women work through over 5 to 7 years in about 2 days. And it's no wonder that those women struggle and find that so tough. But there is also a little bit of data. This is an old study now out of Melbourne, published in 2014, but it's very interesting. And it takes women who've had a breast cancer diagnosis and looked at their menopausal symptoms. Now, none of these women were on adjuvant hormone therapy, so none of them were on anything that was suppressing their ovarian function or making symptoms worse. And they were on average almost 6 years after their breast cancer diagnosis. So long enough that they're starting to get back into where they're at. They haven't had any concerns around recurrence. 90% of these women were menopausal, and the investigators of this study matched these women with community controls of the same age. And you can see down the bottom of that slide that actually those women were significantly more bothered by sleep disturbance. They had significantly more flushes, and significantly more joint pain. And I think it's interesting. The authors of the paper didn't really comment as to why we think this is, but it's interesting to see that often women who've been through a cancer journey actually have a tougher time with symptoms.
I agree.
And of course, many of us are trying to hold down jobs as well. And more I'm doing corporate talks, and I am encouraging workplaces to understand the value that midlife women bring to the workplace. And they bring a huge amount. Statistics New Zealand, they've got that in the next slide, but Statistics New Zealand tells me that in 2025, half a million women are working in the workplace in midlife across New Zealand, and that's between the ages of 45 and 65. And just thinking about the diversity that women bring, the stability, the institutional memory, the institutional knowledge, and the crystallized wisdom, this is a really important group to be supporting over this time. And there's simple things that workplaces can do. Things like bathroom privacy, bathroom accessibility, things like temperature control in the workplace, things like thinking about uniform fibers and natural fibers rather than polyester are all reasonably simple things that show that employees are valued.
Once again, I've had several patients who are very valuable members, and when they actually brought these things up with their employer, the employer was completely comfortable with actually meeting those demands, and it would have been very easy for her to think that I just have to leave and that I can't really ask those questions.
So the research suggests that in the workplace, no menopausal woman wants a big sign over her head saying, I'm menopausal, look at me. But in fact, actually what women are looking for is some quiet change and policy support. And you can see when you look at that graph, just actually this is a significant amount of women in the workplace across New Zealand. And everybody will benefit if we can support these women, particularly the economy. So there's lots that women can do to help themselves over this time. There's good data to show that minimizing alcohol, being a non-smoker, and regular exercise will decrease the amount of flushes and sweats that women are having. There's a bit of data for cognitive behavioral therapy, but those things also are really important for health and well-being in the postmenopausal years as well. Thinking about mood and keeping up your health checks are also important. Do you want to comment, Anna?
Well, the thing that I would say is quite a few of my most successful patients come in and they say, they're sorry to say this, but it was actually they're going to the gym and doing the changes in their diet and fueling properly, which they probably made as much difference as the treatment that we gave.
And I think the really important thing about this is that if you are in a situation where you have a cancer that is estrogen receptor sensitive, the understanding that lifestyle changes can also help to manage these things actually gives you back some power around this time.
So with brain health, it's more important. Yeah. The other thing I'd like to say is that if you're used to doing a lot of exercise and you've now had a treatment that means it's very difficult for you to engage in that or do what you used to do, it's worth doing something.
Oh yeah, everything.
You have just moving is good. Don't wait till you're better to start moving.
Every little bit matters. There has been some criticism out there in the media more recently about us medicalizing this as what is actually a natural event. And I presented this a couple of weeks ago at a corporate, and I said, actually, this is something that everybody goes through, because you're either in the half of the world that goes through it, or you're in the other half of the world supporting the women in your life that goes through it. So actually, we need to be thinking about this as a collective transition. I think there's a lot about menopause that can be positive. It's a lot of hormone stabilization for women who've struggled with hormones in the past. Often endometriosis will settle, significant PMDD or PMS will settle, and there's no longer the need for contraception. So for many women, it can actually be a time of developing a new person, new strength, and a plan for the next 20 years or so. But I also think awareness is important, and understanding this information allows you to understand how this might be relevant to you and make decisions that are right for you.
And I think along that line, the wisdom part, where lots of women, after they have gone through this transition, they sort of look back at those younger women like little girls. They definitely, they feel smarter and more all-knowing.
Okay, so let's have a look at what's actually whoops, let's go back one. There we go. What's actually happening here? So in this graph on the slide, these are your reproductive cycles. So these are what most women have in their 20s, 30s, and some women have in their early 40s. So these are very uniform, consistent cycles. One is the same as the next, is the same as the next. For women who haven't gone through a surgical menopause or haven't gone through adjuvant endocrine therapy, which does change this, then at some point they'll start to move into the perimenopause. And you can see the hormonal chaos that is happening here. So you can see that hormones are going much higher. Often cycles are closer together to begin with. So women are cycling higher and faster and moving through this. This is a really typical time for women to come in and talk to us about breast pain, headache and migraine, and worsening cyclical symptoms. As women move further down this transition, they get less numbers of ovulatory cycles per year, and so less cyclical stuff. Hormone levels are not quite as high. It's really sensitive. There we go. Hormone levels are not quite as high, so you don't get as much breast pain, but you can get more sleep change and night sweats. And then once you get to the last menstrual period, you get a lot more hormone stability here. Want to comment? But you don't necessarily get symptom stability. So this is data about women who've gone through a natural menopause. It's data from the US looking at nurses' midlife health. And this is looking at the number of vasomotor symptoms or flushes and sweats that women have as a hard marker of menopause. The 0 time point here is the last menstrual period. And you can see that women fell into roughly one of these 4 categories of symptoms. These women in the solid line across the top, they're what the Americans call their super flashes. Those women just keep flushing. They're about 20% of women, and they will keep flushing through their 60s, 70s, and 80s. There's about 20% of women down here that hardly get any symptoms at all. Periods just stop and life goes on. The majority of women that Anna and I see tend to fall into this category here, where the most numbers of women are most symptomatic in the 5 years after the last menstrual period. Average duration of symptoms about 7.5 years after the last menstrual period. Here we are 14 years later, and about 20% of these women are still symptomatic. So none of us are saying this is a course of antibiotics for a week, grit your teeth and get through it. We actually need to be addressing some of these symptoms and quality of life and get things that are working for you.
And I think that a trial of treatment is not a failure.
Yes, that is true, actually. I think that's absolutely right. We often see women coming in saying, am I bad enough? Am I severe enough? Should I do this? But actually, just having a go and seeing how you feel.
And if it doesn't work, trying something else
can help answer that question for you. Okay, there are a few symptoms that we wanted to pull out and highlight. And one thing that is getting increasing coverage, I guess, is this early perimenopausal time. I said to you that you get very high levels of estrogen. There's something called loops or luteal out of phase cycles. And that's where we can get the more cyclical symptoms that are coming in, and often the migraine with the changing estrogen levels. Periods can be a bit unpredictable and they can be heavy. And if you're in this stage and you are sexually active, you still need to use contraception because ovulation can be unpredictable.
Yes.
And the natural family planning methods are really unpredictable over this time because you don't really know where you're at. Okay, so I did want to highlight migraine. For women who've struggled with hormonally driven migraines, so migraines with periods, most commonly actually, as your period starts, you get a migraine. These can ramp up and get worse over the perimenopause. And for those who are able to take hormone therapy, this is typically a really effective treatment for perimenopausal migraine. It just gives women a softer landing coming out of that ovulatory loop and dropping down, and it will often stop that migraine or at least make it significantly better. So be aware if you're finding this, that there are generally options that can help.
And just for those people who can't take hormone therapy, there are a lot of new treatments coming out for migraine sufferers who are non-hormonal migraine sufferers. So some of the GPs aren't able to prescribe them and they do need specialist intervention. So once again, it's something that you should look at further rather than just put up with.
Agreed. And get yourself on a public funding waiting list to see a neurologist, because that certainly takes time, but it's worth looking at these options. Yes.
Yes.
The other thing I wanted to highlight is some increasing information coming out about the time of mood vulnerability over the perimenopause. I think we're all really good at asking women after they've had a baby what mood is like, and I'm trying to get women to be considering this early in the perimenopause as well. If you've had a depressive episode in the past, you're at higher risk of mood change over this time. If you've had postnatal depression or cyclical PMDD, so premenstrual depressive disorder, you're at higher risk of getting low mood over the perimenopause. It's often worse if sleep is worse and if flushes are worse, and it can often cause brain fog. It responds well to antidepressants, especially if they've worked for you before, or hormone therapy.
And my only comment there is that with brain fog, before we decide we can't treat it, make sure it's not to do with this. So in other words, brain fog can...
Oh, I see what you mean. Yes, think about whether it's depression driving the brain fog. Yes, agreed. Yeah, it's a really
rather than just putting it down to menopause.
Or also, of course, chemotherapy gives a second hit to the brain, right? And so chemotherapy-induced brain fog. But it's very possible that perimenopausal depression is complicating that.
It's quite hard to tease out depression in this age group, so it's worth thinking of it yourself.
The other thing that we can see over this time is a mental health condition that has been quite stable suddenly destabilizes, right?
That's true, particularly things like ADHD. ADHD often gets worse at puberty and then again at menopause, and women who've been managing it haven't actually got a formal diagnosis. They can't understand why everything falls apart. Having said that, managing the menopause is important, not just managing the ADHD.
And so brain fog is the new buzzword around menopause. 15 years ago, everybody came to talk to us about their flushes and sweats, and now they come in about their brain fog. This here is something called a PET scan. And this is a scan of brain function. And we've got some really nice studies now showing the neurological remodeling that is happening for women over this transition. Often, if you've had chemotherapy, it can be a double insult to the brain. And so it's not uncommon for women in that situation to be more symptomatic than women who've not gone through chemotherapy. If you look at the tests of function, the typical things that women will struggle with will be around short-term memory and what's called verbal memory. So name recall, getting the right word for the right thing, starting a sentence and not knowing where you're going with that sentence. The neuroscientists who have found this are very quick to point out that we never drop below average male scores with the scores of function of this. And I think it's quite important to remember that. Anna and I see a lot of women who lose confidence, especially in the workplace, around this. And I think we notice the change and our partners might notice the change, but often male colleagues probably don't actually really pick it up. Would that be fair?
Let's hope that they're listening.
The male colleagues. This will certainly be worse if sleep is worse, and if flushes are worse, and if mood is worse. So managing those things can often be a really important part of managing the brain fog.
And then once again, I think with a confidence thing, if you're feeling anxious, exactly these symptoms happen, and they're nothing to do with brain fog.
My other comment would be that I know that I don't get all of this for all women with hormone therapy. You know, there's this feeling that everybody must go on hormone therapy for their brain fog, but actually I have had a couple of very high functioning corporate women who I've taken up to very high doses of estrogen, and I haven't managed their brain fog well at all. So it's not all about hormones. It can also be about optimizing many of these other things. And then I encourage women to understand what part of their brain's not quite doing what they're expecting it to do, and then working to compensate for that. And the lovely thing about being in 2025 is we've got some great resources now with AI to allow you and help you compensate for perhaps recording meetings, getting them to summarize the meeting notes. There's lots of things out there that you can actually do that helps you manage everyday life if you're perhaps struggling a bit with this. And I think overall, remembering that your crystallized wisdom is growing can be helpful in those fraught moments. Anything to that?
That's all good.
Okay, do you want to talk about this? Because this is kind of your area.
Oh, you start.
Okay. So the genitourinary syndrome of menopause, particularly wanted to highlight this because I think that it's ignored out there. It's not well screened for, it's not well diagnosed, and it's not well treated, and yet it's a really important part of quality of life. So this is, oh, hang on, wrong screen. Let's come over here. This is estrogenized vaginal tissue under a microscope, and this is unestrogenized vaginal tissue. And you can see what happens is this becomes dry and friable, and the neck of the urethra passes through here as well. So when the end of this becomes irritated, women can present with urgency, frequency, needing to get up at night to pee. This is why many women go to rest homes in their 80s, because they lose their continence. So this is not just about having comfortable sex, although that is important. It is also actually about quality of life as you age, and it's much, much easier to hold on to tissue than try to grow it back. So there's lots of options.
And that's where I will jump in, because we see a lot of women, and we always bring this up right at the beginning to talk to them about looking after their genitourinary health. But women tend to leave it until the last minute, until the symptoms are very bad. And it's quite hard to actually claw you back from that. So as soon as you're starting to have symptoms of dryness, irritation, having to get up at night, leakage, feeling like you might have a urinary tract infection, or getting recurrent urinary tract infections, those are the times when you should be starting to treat it. The other thing too is that a lot of women start off with great gusto, and I've even had 2 or 3 today who said, oh yes, it did work, but I stopped using it. And part of that is because they feel as though it's a little bit messy. And so there are actually other ways of applying it. If you put moisturizer on your arm, you don't just put a lump on and leave it and walk away. And we're encouraging women to actually to dispense it with the applicator onto your finger and actually apply it, particularly to the front area of the vagina where you're actually treating directly those urinary passages, and you can rub it in so that you don't get the sort of fallout the next day. The other thing is that there has been an associated slight increase of getting thrush if you're using these products. And so if you massage it in and use that small amount down at the lower end of the vagina, the lower third, you're less likely to get those problems. Do you want me to talk about lubricants and things here?
Yeah, that's the 3 different options.
Yeah. So the other thing too is that it's worth talking to your oncologist, because a lot of oncologists are becoming much more happy with women using lower dose estrogen than in the past. We like to make these decisions in conjunction with your healthcare team, because some people are more worried about women using these products with their other treatment than others, and it depends a little bit on what else you've tried and what symptoms you are getting. But there are lots of natural products out there. Lubricants are more for intimacy, and they're about tissues sliding on each other. So they tend to contain products that you wouldn't want to use all the time, whereas moisturizers, they adhere to the vaginal wall, and there is lots of different science now. There are some products that are just like face moisturizers, and they just make it feel a bit more lubricated. But there are other products that actually have got qualities that adhere to the wall, and they actually trap moisture and make the area much more sort of like a normal
normal vaginal wall, really. They
Yeah.
make things more like this and less like this, right?
And so they actually do provide a lot of comfort. Now, once again, it's a matter of trying different ones. Some people find some a bit thin, some roll into balls, some seem to make a bit more mess. So it's worth trying the different options. And there are other options which, apart from using the cream, sometimes the Overstin cream people actually react to, and there are other options that are available where you can actually have devices to slowly release estrogen. But once again, they probably need to be organised through a gynecologist.
So there's lots of different options, and it's worth a discussion to think about.
And the options are expanding.
Yeah, they are. Okay, so let's go on and talk more about management of systemic symptoms. And the first question that we always ask when we're seeing women who have had a cancer diagnosis is, how hormone responsive is your cancer? Who else is involved in your care? Have they given us any direction about what we're able to use and not able to use? For women who have had hormone-stimulated cancers, and the most common ones we see, of course, are women with a breast cancer or a DCIS diagnosis, then the basic rules are to look at non-hormonal options first line, and we're going to talk to you about those. Consider the genitourinary health, and Anna's right. More and more, we are becoming increasingly comfortable with women using vaginal estrogens. The only group that we now think twice over as women who are also on aromatase inhibitors, and that's always worth a wider discussion, and then thinking about bone density. So every international guideline that you pick up says this, that for many women under the age of 60, less than 10 years from their last menstrual period, hormone therapy is first-line treatment for menopausal symptoms, lowered bone density, and the genitourinary syndrome of menopause. I alluded to this right at the beginning, but the first thing that we are thinking about when we sit with somebody is, how old is this woman and what's happening to her hormones? Because if you're estrogen deficient before about the age of 45, then we are starting to think wider than just your symptoms. We are thinking about bone health and heart health, as well as symptoms and well-being. Between that age of 45 and 60, then that's when we're thinking about treatment for symptoms. We're worried about what your bone density is. Do you have any genitourinary syndrome of menopause? And for women over the age of 60, then that's a more careful discussion about benefit versus risk and what we're hoping to gain and what we need to think about with regards to vascular risk and breast cancer risk.
Nothing to add.
So this is what hormone therapy looks like. So typically we use estrogen and progesterone. Just going to fast forward one slide. So for women who have had a hysterectomy, then those women typically can just use estrogen. For women who have not had a hysterectomy, then we use the estrogen to treat the symptoms and the progesterone to control the bleeding and protect from any thickness of the lining of the womb. And if women have within 12 months of their last menstrual period when they start, then we use this cyclical regimen. And if women are past their last menstrual period, then we use this continuous regimen, and it's not supposed to bring back periods. So this is what the options look like. With the estrogen, there is a patch, a gel, or an oral estrogen tablet. And with the progesterone, typically gold standard options would be the natural body identical progesterone, which in New Zealand is called Eutrogestin, or a Mirena IUD. But there are synthetic progestins as well, and sometimes in different circumstances we use those. This is what we're telling women currently in 2025 around risk of using these medications. If you've had a hysterectomy and you're just using estrogen, and if you use a transdermal product, so a patch or a gel, then there's really no increased risk of anything for those women. If you're using oral estrogen, there is a tiny increased risk of clot in the legs and the lungs. But the data around estrogen by itself suggests no increased risk of breast cancer. For women who haven't had a hysterectomy and need to use estrogen and progesterone, then there's no increased risk of heart disease or stroke. There is no increased risk of clot in the legs and the lungs if you're using a transdermal product. And if you start hormone therapy around about 50 and you carry on past about 57, 58, 59, then ongoing hormone therapy use for women involves a breast cancer risk of about 1 per 1,200 women per year. Just to give you some perspective on that breast cancer risk, that's a similar kind of risk that women choose to have if they choose to have 2 alcoholic drinks a day, and about the same risk of breast cancer as being a smoker. So it gives you some sort of perspective on what that risk means.
Just checking that women know that these are women who haven't had breast cancer.
Yeah. So if we move on and talk about non-hormone alternatives first, this is what I meant when I said that for women who have had a hormone-dependent or hormone-stimulated cancer diagnosis, this is where we start. It's a much trickier discussion around using hormones for women who've had a hormone-stimulated cancer. So probably first-line management for many women would be the SSRI or the serotonin medications. The way I use or both Anna and I use these medications is that we see the flushes and sweats as the primary outcome of these medications. And then the side effects we see as things like mood improvement from SSRIs. So we tend to choose which one to use depending on what's going on for women. So the SSRIs like citalopram, sertraline, venlafaxine, these medications will help about 20% of women with flushes and sweats, and they're really good for women who are struggling with anxiety or low mood over this time.
In fact, it's probably one of the first-line treatments that lots of GPs use for younger women who've got PMDD. So it's very effective in managing the sort of hormonal symptoms.
Gabapentin, some of you may be familiar with this as a pain relief used after theatre. We use gabapentin because it will also help about 60% of women with flushes and sweats, and the side effect of sedation and helping with sleep is really useful for women who are struggling in this time with sleep.
And it's another one that's used as a sort of third-line option for anxiety.
Oxybutynin will help about 40% of women with flushes and sweats. It's a medication used for bladder reactivity. The side effects of that can be dry mouth, abdominal pain. That doesn't really give us many positive other side effects. Would that be fair?
No.
And different women will respond to different things. So it's absolutely worth working your way through these different options. Fezolineant is a new medication in New Zealand. At the moment, it's not funded. It is part of what I'm enthusiastic that the Australasian Menopause Society get behind, is getting some funding for this medication across Australasia, actually, because I'm seeing some women who are funding this themselves, and we're seeing such significant improvement in the flushes and sweats. At the moment, this is around about $250 a month to use. It reacts with one of the pathways in the hypothalamus that generates a flush. And for the women for whom this is effective, I can see women go from hourly flushes to maybe 1 flush a day or every 24 hours or 1 a week on this medication. I've also seen some women who drop their doses down once they've gained control to perhaps 1 every second day and are still getting really good control of flushes. So it's very possible that you might be able to decrease the cost of that medication. I think this is going to be something that pharmac are going to have to look at quite seriously. There's also something called a stellate ganglion block. So this is a treatment for flushes and sweats, and it's when the radiologist will find a group of nerves that run down the front of the neck there and inject it with local anesthetic. And you can see in the graph at the bottom of that slide that the closed filled-in circles are the women that had the sham procedure. They just had normal saline injected, and the open circles are women who've had the local anesthetic. And you can see that there's really not much difference in flush management at 1 month, but after month 3, it starts to become statistically significant with less flushes in those that have had the treatment group. There's really no side effects with this.
It looks scary in your picture.
Yeah, doesn't look great, does it? But there's really no side effects. On the side that you've had injected, you have what's called a Horner's syndrome for about 6 hours afterwards. It's when the lid drops and your pupil gets a bit bigger. That's how we know we've got the right nerves. We actually want to see that. But that resolves spontaneously and goes away, and we really didn't see any other side effects. Okay, let's move on a little bit and just finish by talking a bit about libido and testosterone. There's certainly lots of questions with this. This is very much a doctor's look at libido and testosterone. I would absolutely make a plug for psychologists that work in this area and sex therapists. I think they have so much to offer in this space for women. It's quite tricky to get women to see a psychologist around sexual concerns or sexual issues. It's quite scary. But most women...
And in this space too, I think that those psychologists are particularly good at making you feel like a woman again. Like after you've had all the surgery, I feel as though it's more than just the libido that they treat. They treat looking at you.
Finding yourself again. And most women who I can get to see a psychologist or a sex therapist come back to me and say, it was really scary sending that first email or making that first phone call, but I'm really pleased I did it, and I wish I'd done it 5 years previously. So do think about that. Now, there's lots of things that feed into female libido. This is certainly not all about testosterone. So there is lots of components. Female libido is always very fragile, and it's always the first thing to go if things are not right elsewhere. So what we think about when we're thinking about libido is somebody's physical health and their hormonal health and how that might have affected things. But anxiety and depression can be pretty toxic for libido, and psychological health is really important. Self-confidence can absolutely be impacted by a cancer diagnosis, and finding that self-confidence again can be really important in terms of managing libido. We do a lot of screening for the genitourinary syndrome of menopause because there's not much point in talking about libido or even considering testosterone if sex is painful, right? Nobody wants to do what's painful. I think that's a completely natural reaction. I quite like this term good enough relationship. Nobody has to have the perfect relationship, but actually you do have to have a reasonable relationship that you're invested in. And thinking about privacy, the environment, and what's your to-do list look like and how attached to your to-do list are you, because that will absolutely impact on libido.
Yes, someone told me that women are like Ferraris and we just have to have everything finely tuned.
So these are the kind of different approaches I've picked up over the years of listening to lots and lots of sex therapy talks, most of which I've come out of with pearls of wisdom. I think the first thing to comment on is the normality of this. The typical thing that I see is women who are in heterosexual relationships, and they come along and they tell me that their partner tells them there's something wrong with them. And I think that testosterone is such a dominant hormone for men, and I am about to generalize, but testosterone...
They are V-dubs.
Yeah. Yeah, that's true. They don't need such fine tuning. But most men don't have to work very hard to keep libido very high in their priority list, whereas women certainly need to work a bit harder because we just don't have the same hormone makeup. And I think it's completely normal for libido to come and go, fluctuate, not always be where women want it to be or are told by social media, films, everything else is exactly where it should be. I think it's completely normal to not be there. Now, one of the best talks I ever heard was Helen Colliglin was this wonderful sex therapist in the Waikato who has now retired. But she talked about the fact that the thing that helps everybody's libido is to change their partner every 2 years. And actually what she tells her patients is to have an affair with their partner every 2 years. And I find that a really helpful tip. So I tell women to go away and make a list of all the things that they would do if they were going to have an affair. Pick one a week and then feed it back into their relationship. And for some women, that works really well. The diary approach is also an option. So diary when you're going to have sex. Actually, I'm pretty sure it was the New Zealand Herald a few weeks ago, or I think they stole an article out of the Telegraph that profiled a woman who was talking about Thursday mornings. So her and her husband worked from home on Thursday mornings, and they would ship the children off to school, and then they would come home and go back to bed for an hour or two, and they both knew it was going to happen every week, and it was really working
Well,
for her.
there's a Flight of the Conchords song called Business Time on Wednesday.
So I think the diary approach is something that absolutely works for some women. Picking your time as a time that works for you is part of that. The hormone approach, and I'm about to talk about testosterone. Reclaiming sexuality. So on that slide, we've got a couple of books that we do a lot of recommending to women. Come As You Are is a fantastic book by a sex therapist whose name is Emily Nagoski. She's done a much wider look at female sexuality. Rosie King is an Australian sex therapist. Where Did My Libido Go? And she looks much more closely at that menopause transition, libido change. But I'd absolutely look at both of those books, look at the reviews, see if any of that clicks with you. There are a lot of resources online. And on our website, I have written a blog on libido, and I've listed some of those resources at the bottom of it, so you could have a look at it. And then the multidisciplinary approach, that's really the plug for the psychologists and the sex therapists who just have so much to
And
offer.
maybe gynae physio if there's a pain issue.
Yeah, absolutely. Yep, they can be really important as well. And doing your Kegel exercises. So those pelvic floor exercises, which are those exercises that you do when you try to stop the urine flow when you're peeing. Next time you pee, if you try to stop, you'll feel all of your pelvic floor muscles contract. They're the same muscles that you use when you orgasm. So actually you need to keep those moving. 10 in the morning and 10 in the evening will certainly help sexual function as well as urinary continence. So we're getting lots of questions and lots of queries about testosterone, and I did want to just comment on that a little bit. Testosterone's out there on social media as managing absolutely the world, and what we actually have science for is to show that it helps women with low libido. Now, the official terminology for that, which I hate, is hypoactive sexual desire disorder. That I can't bear that because I don't think that women have a disorder in this area, but nevertheless, essentially what that means is that libido is low and it's distressing to that person sitting with us. That's really what we're looking for. Supplementing testosterone for those women who are menopausal will improve libido for about 60% of women. And a positive response is defined as 1 to 2 more satisfying sexual episodes per month. The product of testosterone that we use is Androfem. This is the only testosterone delivery product designed specifically for women, available around the world at the moment. Actually, that's a lie. The Americans have a slightly different product. But this is designed for women, and it gives a consistent dose day after day after day. Takes 4 weeks to have a clinical effect, and effect peaks at 3 months. And we do intermittent testosterone levels, really to make sure the delivery method is a bit fiddly. Many women throw it away and just put a bit on the end of their finger, and then we see it start to rise. Whilst the data in women who have not had a cancer diagnosis is reassuring in terms of no increased risk of breast cancer, we have no data around using this in women who've had a breast cancer diagnosis. Some testosterone is turned into estrogen, so it's always a careful discussion. Okay, so there's lots of open access information on our website, and I'd really strongly encourage you to have a look at some of it. We've put together some resources around a free coffee group, so you can sit with some friends and discuss it. These are 2 books that are out there as well that give you some really useful information. They're both written by health journalists. And the Australasian Menopause Society. Oh, no, I didn't include that slide. Let's just go back a moment. The Australasian Menopause Society is also a website where you can get some really great evidence-based information. We have just released our app with our new Basics Menopause course on it, and the first module is free open access, so you can get a little bit more information there too if it's interesting you. And Anna and our other specialist GP, Paula, are doing consults in our specialist clinic in Auckland. So I'll open up for questions in a moment, but I'd really encourage you to think about if this is affecting you, how this is affecting you, and writing some of this information down so that you can go in and talk to your doctors about this. We'd encourage you and your doctor to think about the whole picture, because it's possible that your cancer or your cancer journey is probably changing where you're at and what options are available to you. Do you have anything to sum up with, Anna?
No, just I think the fact that you that you might find it more helpful if you have some ideas and go to your GP, because they're more likely to engage rather than be frightened about the responsibility that they feel that they might have if they know that your specialist team's involved.
Do you want to comment on booking a double appointment?
Yes, it is really important. I've actually left general practice, and one of the reasons I did was because it was just impossible to deal with all the things that come up. When you have come from a menopause discussion, it's really a midlife checkup, and ideally you need an hour with your doctor to actually discuss all of this. The next best option is to organise a couple of double appointments and maybe deal with some of the issues at each one. There's absolutely no way it can be done in 15 minutes.
Wonderful. Thank you, ladies. Look, for a start, I just want to say a huge thank you for that presentation and all that you bring. And I know it's a huge topic area, but it's something that's incredibly close to everybody and affects absolutely, like you say, 50% of our population. We've got a question in the chat, and then I've got some pre-submitted questions that we'll talk to as well. So the first one here we've got on the line is, post-chemo, I've got sore bones. My hematologist said it's likely menopause. So any suggestions there?
Sore bones. Yes, it may well be menopausal. It's really going to come down to whether hormone therapy is appropriate or not. And if it's not, then it's really treating those sore bones symptomatically with a non-steroidal and paracetamol, if that's possible. Often gabapentin as well can be useful at night.
And don't forget exercising and moving.
Yeah.
Sure. Fantastic. Thank you, ladies. So we'll just go now to our submitted questions. So we've got one here. I had triple negative breast cancer. The tumour is gone with chemo and lumpectomy, showed no more cancer cells. I had radiation as insurance. I'm experiencing excessive hair growth on my face. Is this hormonal, and will it continue or will it subside?
Possibly. The hair growth that tends to be hormonal is thicker, blacker hair. It is worth just getting your GP to do a serum testosterone level and make sure that that's not particularly high. What tends to happen over menopause, though, is the estrogen-testosterone ratio changes, and so it tends to encourage hair growth. There are treatments that would be possible with a hormone receptor negative breast cancer that probably with time would give some control of that.
Okay, thank you. And a few people have sort of probably asked this question, is how to get energy and spark back for life after cancer. And I guess, that comes hand in hand with those menopause symptoms.
I mean, I think it's looking at all the different components that is going on in that person's life. So what's happening to sleep, what's happening to exercise, what's happening to mood. Those would probably be the big things. And diet. Yes, that's a good point.
Fueling.
So making sure, we certainly see many women who are desperately trying to manage weight, who are following that old adage that it's all about calories in versus calories out, and are just restricting and becoming energy deficient and then very fatigued. So fueling is really important, and perhaps getting some advice around that. And then thinking about whether you can use hormone therapy or not use hormone therapy and what that means for you. But there's a lot you can do in that space before you reach for hormone therapy.
The other thing is a lot of the lifestyle things are restricted by people's pain and feeling tired and maybe not wanting to eat. So it's actually worth talking to your doctor about the side effects of medication so you can actually do those things.
Sure. So with that, then I guess there's a question here, what supplements can we take to improve bone density against effects of Zoladex, tamoxifen? How long do hot flushes last on tamoxifen? And any tips to reduce the impacts, which you've talked a little bit about that as well.
So bone density should be being assessed. Tamoxifen actually doesn't really bother bone density much, but aromatase inhibitors do. But the oncologists are generally very onto that and are measuring bone density. You should look at your recommended daily intake of calcium. There's online calcium calculators to help show you, and we want you sitting between about 500 and 1,000 milligrams a day. We would love you to get that from dietary sources rather than supplements. There's some concern that supplements can drive heart disease. But if we're really struggling with dietary options, then we will use a small number of supplements. Most women get enough vitamin D in New Zealand to manage bones just from everyday movement around the community. But if there's a real reason why somebody might be very sun avoidant, then a vitamin D supplement can be useful at least over winter.
Sure. I think that's just about us now, ladies, but as I say, a lot of it was about those psychosocial symptoms like low mood, brain fog, anxiety and depression. So is there anything that you'd like to add in that vein?
My feeling is that the anxiety depression one is something that you can use non-hormonal treatments for. And so in terms of that space, getting a talk therapy, seeing someone who's a psychologist, eating properly, exercising, doing things that are fun, making sure that you maintain your social engagement. Don't forget those basics, but also managing sleep and mood with non-hormonal treatments is actually, you can actually achieve that.
And I guess a little bit's like having those rituals that you do every day, isn't it? Sticking to those same things that you're doing constantly.
And keep in contact with other people.
Sure. Wonderful. We may have, I'll just check our questions here. Okay, here we go. I was advised not to do anything until the end of first year after chemotherapy to ensure that menopause had set in and was not just temporarily induced by the chemo. So is that good advice? Would that be right?
I think it's really tricky for us to answer that because we don't know how old that person is, what cancer they've had. I think that's quite an individual answer and question.
So that would refer back to GP, wouldn't it? Medical practitioner. Yeah, sure. How long can you stay on gabapentin, and are there any withdrawal symptoms when stopping?
You can stay on gabapentin indefinitely if you want to do that, and I would drop it down quite slowly for people and bring them off to manage symptoms slowly rather than stop it cold turkey.
My experience that everyone is so different, and some people do just stop it, some people actually can't tolerate it, some people have no side effects, and that's why I said if something doesn't work, try something else. Don't just think everyone else you know didn't tolerate it. You might be different.
Sure, wonderful advice. Ladies, thank you. That's all our questions on our chat and the ones that we've submitted. And I don't think anybody's got their hands up or waving their hands up anywhere. So I think that comes to the end of our session. Look, I can't thank you enough for the advice and the way in which you've presented today, which has been absolutely empowering and endearing. So thank you very much. Round of applause for you from our wonderful audience out there.
That's great. Thank you. Thank you for some good questions. It makes a real difference. Have a nice evening, everyone.